to the next presenter, Dr. Hao Yuan Chen. We will talk about the hysteroscopy.
Thank you. Thank you, Professor, for your kind introduction. I'm Dr. Chen Hao Yuan. I was born in Malaysia and I now practice in Taiwan. Today I'm going to talk about the role of hysteroscopy in RPOC. And also I would like to emphasize the importance to stop DNC. Here's the outline of my presentation. And first of all, let me explain that RPOC refers to any tissue left in the uterus after either an incomplete abortion, elective termination, or a viable delivery. It is actually not very uncommon. As you can see, the overall prevalence is about 6%, and it is even more common in early pregnancy loss and elective termination. The clinical presentation of RPOC includes bleeding, fever, pain, and amenorrhea after 6 weeks. When it comes to the diagnosis, ultrasound is often our first tool. When you see a intrauterine content with Doppler flow, it is very likely to be an RPOC. And you can also classify the RPOC according to the vascularity. If there is no vascularity at all, it is a type 0. And if there is some flow, but the flow is less than the flow of the myometrium, it is type 1. If the flow is about the same as the myometrium, it is type 2. And if the flow is even more than the flow of the myometrium, it is a type 3. But since we are gynecologic endoscopists, we have an even better tool, which is diagnostic hysteroscope. There is a study, I have the reference here. The study recruited hundreds of women with early pregnancy loss, and they have all of the women to undergo both ultrasound and hysteroscope. What they found was very shocking. In those women whose ultrasound was normal, actually 24% of them have some RPOC in the uterus. So if you only diagnose RPOC with ultrasound, especially if the patient is still bleeding, you are going to miss a lot of the cases. As a result, I think we need both. Ultrasound is very cheap and it allows us to assess the vascularity. And hysteroscope is more accurate in the diagnosis, and it also provides a direct visualization, which is essential for our surgical plan. It is reasonable to treat the RPOC patient medically if the patient does not bleed a lot and if there is no flow in the RPOC. But if the patient has profound bleeding or there is extensive flow in the RPOC, then the patient most probably gonna need a surgery, which you have two options. The first is DNC, and the second is hysteroscope. DNC is a classic gynecologic procedure, but it is blind, so it has a higher risk of intrauterine adhesions and also a higher risk of incomplete resection of RPOC. Regarding IUA, there is a joint statement between AAGL and SG. They concluded that the incidence of intrauterine adhesions is higher in DNC and lower in hysteroscope. When it comes to incomplete resection rate, there is a study that found that if you choose to treat the RPOC patient with DNC, there is a 1 in 8 chance that the patient will still have persistent RPOC after the DNC, and they're gonna need another intervention for complete resection. While in the hysteroscopy group, the rate was 0. Next, I'm gonna share 2 cases of my own. The first case is a RPOC after spontaneous abortion. Okay. This woman was 34 and she had an incomplete abortion. She has already received medical treatment elsewhere, but she continued to bleed for a month. And ultrasound shows that there is extensive flow, so it was a type 3 RPOC. I'm just gonna show you the video real quick. As you can see, I actually started with a shaver, but since it is type 3, it bleeds very easily. So I end up having to switch to a resectoscope for hemostasis. And you can see in the end, we have removed all of the tissue from the uterus. Okay. The second case is a persistent RPOC after a DNC. This woman has 3 elective DNC before, and her 4th pregnancy was a missed abortion. She received another DNC for the missed abortion, but she continues to bleed for more than a month after the DNC, and it was a type 2 RPOC. As you can see, there is a quite large tissue in the cavity, even though the patient has already received a DNC. So this reminds us that DNC does not always remove everything from the uterus. And you can see, in the end, the cavity is very clean. And just a few months later, the lady got pregnant again, and last month she delivered to a baby boy. Okay, here's my take-home messages. The first is, I think we need both ultrasound and hysteroscope to diagnose RPOC. And you may treat the patient medically if the patient is stable, does not bleed a lot, and it is a type 0 RPOC. If you need surgery to treat the patient, hysteroscope is preferred over DNC. And finally, if you, for whatever reason, you still want to choose to perform a DNC in such patient, please just do it for one time. Never do it more than once. That is no second DNC. So here I provide a sample algorithm for you guys. You can feel free to take a photo. As a gynecologic endoscopist, I believe that our ultimate goal is to abandon DNC altogether. But this paradigm shift is gonna take time. I believe we are somewhere in the second stage over here. So I would like to invite all of you guys to endorse this no second DNC policy. Just imagine if you perform a second DNC to an RPOC patient. Remember that there is a 1 in 8 chance that the patient is gonna need a 3rd surgery. So do you think that patient will be happy, will be satisfied? Or maybe you receive a letter from the patient's lawyer, right? So no second DNC, please. And of course, no second DNC is good, but no DNC at all is even better. This is the end of my presentation. Stop DNC. Thank you.
Okay, it's very amazing presentation. Okay, we open for discussion. Any question from floor? From audience? Please.
When you do the resection, do you
Yes.
use electricity or it's just blunt scraping?
I will try to use blunt dissection for most of the time, but